what I'd like to do is, on behalf of faculty development, really welcome you to the first ever Premier Education Banquet. And thank you so much for taking time out of your busy schedules to come across campus to the Field Club. This event arose because we thought, we really needed a stage to showcase some of the really innovative things that are happening in every college and every unit, and to figure out what are some ways that we can disseminate that information, who are the other educators that we need to meet, and really, how do we become ambitious enough to be this premier education institution that shares all of its, great ideas, creative output together? So this is going to be our first ever event, and we're very excited that you guys are here to help us celebrate it. So, as I mentioned before, there's going to be quite a few speakers, and these are listed, and they're also listed in your. I think you have handouts there as well. But each one will probably speak for about 5 minutes or so, except for our two bookend speakers. And basically, they're going to tell you about a big idea, something that they're very proud of, things that we thought from the 50,000-foot level other people ought to know about. And we really hope that it'll stimulate discussion at your tables. Because of our ambitious agenda today, we're going to save all the questions to the end. And so as you see things that you find inspiring, things that you want to ask a little bit more about, please jot it down, and then we'll save time at the very end to ask those questions. We also are going to be recording all of these speakers today so that you can also view them, and for your colleagues that could not make it, that you could also point them to look through some of these slides and some of these presentations. So this is going to be our schedule today. And really the idea is that we want to take whatever silos that are out there and break them down, and show, if there's a great idea on competency-based education over in this unit, can we look at how that translates over to this other college? If someone's doing something really innovative for, teaching or learning, how do we make sure that I bring that back to my colleagues and my faculty? And that's really the whole idea today. It's my pleasure to introduce our first speaker, who really needs no introduction, our Chancellor, Dr. Jeffrey Gold. And as you know, he's not only a senior leader of many of our operations here, clinical, research, and so on, but also he's a tremendous educator and has national experience serving on over 50 different organizations in very senior positions in education. And really, we're asking him to come up here and give us a frame for being bold about education and how we're going to become and really maintain this tradition of excellence as a premier education institution. So please help me welcome our Chancellor, Dr. Jeffrey Gold.
Well, thank you so much for the introduction, and thank you so much for the opportunity to spend some time with you while you're eating, and please do eat. I usually get the unenviable position about being the last person to speak before somebody gets to eat or the end of a meeting, so people are getting fidgety and watching the time, but this is really a true privilege. So when I was asked to do this, they asked me if I would prepare a slide deck, handouts, etc. But I have no slides, I have no handouts, and I have no notes. I am going to attempt to speak to you from the heart about educational innovation and some of the thoughts that I've gleaned over several decades as an educator in the trenches in the health professions. I have had the opportunity of being directly responsible for the education of nurses, pharmacists, physician's assistants, physicians, and many other healthcare professionals, as well as had the opportunity on a leadership level on several boards and organizations to think through where we are and where we're going, and even more recently to listen to the public opinion on how we're doing. And so if you were to take the 50,000-foot view, if you were to go to the austere halls of the United States Congress, if you were to go to the various offices in the state houses across the country and ask the question is how is the health profession doing in their educational processes, they would tell you that it's broken. They would tell you that, and as I love to tell these people, I represent that remark in the truest possible sense because I have been involved in developing the programs, in creating the policies, in looking very carefully at the funding structures, trying to make the best out of them. But I think when people look at us, at what we do, they are dissatisfied. Not to say that they don't love the relationships that they have with the nurses and the dentists and the pharmacists and the physicians who care for them, but they don't think that we are creating the health workforce for the future. Not that they know what that is, but they don't think that we are. They don't think that we are adequately shepherding the resources that they invest, and they invest a huge amount of money in health education professions, both on the level of Pell and Stafford lending, which has now exceeded total U.S. credit card debt. By the way, it's going to make the housing bubble look like nothing if we can't get our hands around it. They think that there have been major deviations in the professionalism, not that they would ever question the professionalism of those that care for themselves or their families, but that they have witnessed all too often deviations in the quality of care, errors in medication, errors in decision-making, if you will, the non-professional aspects of the health profession's practices, and they are more than willing to call that out. And so while I look at the audience like this and the program that you're about to sit through as visionary, inspiring, and I know that I am truly preaching to the choir, quote unquote, I think it's only fair that I share with you some of the sentiments and concerns that are being raised on a national level. Now, there are only a fixed number of responses that we on a national level can take to that, and I spent the first 2 days of this week in Washington, D.C., addressing some of these very issues with shall we say, a very austere group of senior leaders about the relevance of what we're doing, the sustainability about what we're doing, and essentially advocating for continued investment in the future of the health profession's education as we know it, rather than blowing it up and starting from scratch. Again, not that these people have any brilliant idea as to how to blow it up and what it would look like, but they are looking at what we're teaching, and they're really concerned about it. So I would say that the challenges are sort of arrayed as follows. The first question is, who are we teaching? How are we selecting young women and young men to be our students today, and do we want to rethink that process tomorrow? Does the ability to take a number 2 pencil and fill in a tiny little circle on a piece of paper, or the computer equivalent of that, actually equal the person or cohort that are going to be the best and the brightest and have the most sustainable careers? Another question that I hope you're going to deal with is, what are we teaching? You know, we spend an awful lot of time discussing how we are teaching, the pedagogy, or better now known as the andragogy, as these are basically adult learners. But we are spending a lot of time on flipped classroom, high technology, simulation, upside-down learning, adaptive systems, blended curriculum. And believe me, I've spent the last decade and a half of my life involved in thinking about those thoughts, and they're wonderful because they relate to how people acquire and retain useful information and how they ultimately use and transmit useful information. But I don't think we've spent all that much time thinking about what we are teaching. Is the curriculum current? The content of the curriculum I'm talking about from a purely educational perspective. And that gets into some very, very difficult questions. I mean, we have taught the same content in all of our specialty areas for a long time. Sure, we have evolved it as technology has evolved, but I'm not so sure we've taken a really hard look at what is being taught as much as we are about how we teach. So interprofessional education is one aspect of what we teach and how we teach, but I'm not so sure that we've really kicked the tires on that as hard as we can possibly kick it. Another major question, forgetting for a minute who we teach, how we teach, and what we teach, is how we assess. How do we assess the outcomes? Again, is it the ability to answer multiple choice questions, to have a structured interview, to be videotaped with a simulated patient, or to count the performance time for 100 endoscopies in the sim center? Is that the way we assess or are we missing other areas? Because we talk about the core competencies that we want to teach, and we, of course, talk about moving from a time-based to a competency-based curricular model. But implicit in that is if you're going to move from a time-based curricular model to a competency-based curricular model, one has to be able to assess the outcomes of that in a reliable way. After all, we have a moral and ethical obligation to society to turn out a cohort of healthcare professionals who are frankly good enough to take care of us, our families, our children, and our grandchildren. And the last thing in the world we would ever want to do is compromise any of these parameters to do anything but educate to that level. And I think at the end of the day, that is the goal of this meeting and any meeting regarding education is what are we doing for the next generation of health professions workforce to be sure that we would be perfectly comfortable to ask them to care for our children and grandchildren and great-grandchildren when that day comes. And don't forget the knowledge and skills, the professionalism, the attitudes and behaviors that they will acquire, they will carry with them through a 30 to 40-year career. And so that will be enduring for a long period of time. And so we collectively, at our institutions, in our colleges, in our programs, and across the United States, teach to the test. So in the medical school world, we teach to the USMLE step exams. In the nursing world, we teach to the NCLEX, and on and on and on. And I'm not sure that as health professional educators, we have really asked the question as to whether that is the be-all, end-all goal. It is the ticket to licensure in many of the health professions, but it may not be the ticket to the most competent workforce that we want. And as we think about movement to a competency-based education, we have to be able to answer that question is, are we truly educating a generation of healthcare professionals who are competent? So again, in summary, what I hope that you will address today, but that we will address as a university moving forward, is who we teach, how we teach, what we teach, how we assess. And I would even suggest to you that some of that assessment is not going to be available for 10 years after they finish the educational process or even more. I mean, one of the very interesting questions we debated earlier this week in Washington is, what is the end point of that assessment? How do you know whether an educational program is really working or not working? It really has to do with the quality of care that those individuals deliver, not just the quality and safety side of it, but the patient-centeredness side of it, how they are respected by their community, etc. So those are difficult challenges because those are not endpoints we have within our grasp. An NCLEX score is a lot easier to do standard deviations and averages on and point to and say, aha, we're meeting the grade. I'm not so sure, though, that it is the person with the highest NCLEX score that you want to be your bedside nurse or your child when, heaven forbid, she or he is hospitalized. These are serious challenges. They buck the paradigms that have existed since Flexnerian education was even first conceived over 100 years ago. It takes great risk and, frankly, great courage to think about these questions. But I actually think that the University of Nebraska Medical Center, all of our health professions colleges, are uniquely positioned to ask and to answer these questions, to take those risks. Now, why do I say that? Well, first of all, the faculty and the leadership and the deans and the university fabric itself, I think, is very stable. It has a long tradition of excellence. So you're building on a platform of people who get it. That is to say, the quality of the workforce that we have developed that now serve our communities, but also become our junior faculty who we then assimilate into it, are very high quality. So we're not starting from a position of weakness. Another reason is that we have been willing to take risk. I think some of the things under Dr. Davies' leadership and others around interprofessional education, around some of the thoughts we're having about simulation and virtual immersive reality, team-based care, etc., are right on. And so we have been willing to take some risk and to think out of the box. I think the changes in the governance structure of the medical center and the access to a gigantic, well-functioning teaching laboratory where we can not only experiment a bit on clinical teaching paradigms, but also have an environment where we can assess the outcomes with real-time clinical outcomes is also unique. And we're well positioned right now to do that. And then were that enough, I think the resources in this community nationally are present. And I don't necessarily mean just the magnificent fiscal plant or the financial resources provided by the state or by other means, but I mean the people. I mean each and every one of you. This is an environment where the faculty of this university are willing to roll up their sleeves and say, we can do that. We're up to that challenge. It's going to be hard work. There's going to be risk associated with it. And we may not exceed in every single one of those projects, but we're willing to take the risk. We're willing to extend ourselves and for the betterment. And I think that the thoughts that will come out of this kind of conference and the thoughts that hopefully will permeate your curriculum committees will reflect on some of that. Now, I can tell you, having spent 6 years on the board of the LCME, having been involved in many other accrediting organizations over the years, that saying that the accrediting bodies and the national groups are not going to tolerate that kind of change, that the people who write the NCLEX and the NBME and others, the overall alphabet soup of assessment and quality, are not going to allow change. I will tell you that that's nonsense, that I have yet to see a single viable proposal for changes in curriculum, for changes in andragogy, for changes in assessment pushed back on. Just to give you an example, there's a proposal and an ongoing pilot in Oregon Health Sciences University that will reduce the entire length of medical school to 2 years. Now, I mean, that's really thinking out of the box. And I can tell you that there are any number of people in Washington and elsewhere who think that the entire length of a health professions education, including all of undergraduate school, graduate school, residency and fellowship training, should be no more than 7 years soup to nuts. And this was based upon an economic study on return on investment of what the tuition dollar could buy in terms of lifetime earnings and impact on society. Now, I mean, that number is a lot longer. I mean, for myself, that number is probably almost 20 years, you know, so I think about what that would have meant to the productivity of a career if you could get that down to 7 years, and hence the tremendous interest on a national level as to what we're doing and why we're doing it. So I guess in summary, first of all, I thank you for the opportunity to sort of kick off this event. I commend the organizers greatly. I think it is wonderful. I'm deeply sorry that I can't be with you for the entire length of the event. I actually am going to be doing a greeting over in the Trulson Events Center for some of our incoming students, and I love those events. They are really invigorating. They provide incredible inspiration to me as to why we all get up every day and go to work. I mean, what we do is we change the world, and on the educational side, we change the world by creating the next generation of people who are going to carry the same value set and have the same vision that we do. And so I thank you for the opportunity. I wish you the very best in your conference. I look forward to learning more about these programs. But I hope as you go through the day, you will think about those questions of who we're teaching, how we're teaching, what we're teaching, and how we assess it and what the real end goals are. You know, I would suggest to you that a lot of the end goals that we currently cherish are really surrogates for much more meaningful outcomes, and that it's time to get down to the question of what those outcomes really are. Thanks a lot and have a great afternoon. Appreciate it.
So I'd like to thank Dr. Gold for that wonderful introduction, and really a challenge for us to really think about these deeper-seated issues of when we are bringing our new students onto campus, how do we make sure that they truly are the best they can be in as fast a time as it can be, but also with some of these principles about, you know, competency-based education. How do we make sure that we are proud of every single one and that we are making sure we're pushing the envelope both here and nationally? So really a great talk, and something that I think will underpin a lot of these ideas as we go ahead. What I'll do is I'm going to speak on behalf of faculty development programs, and we do many things on campus, but the big idea I want to talk about is the idea of a teaching academy. So when we have these innovations, how do we make sure that we spread them across all of our faculty? How do we make sure we truly have a community of all the, not just the distinguished educators, but the emerging educators, the folks that have just come out of our training programs that are really keen on becoming the next generation of program directors and course directors? And how do we take these innovators and connect them to the resources they need to feel supported, just as we do for our most senior researchers in basic science and other areas? So that is the idea of a teaching academy. And basically, this idea has permeated nationally. There are about 36 or more teaching academies across medical centers now across the U.S. And this idea has floated here for about 20 years, and we hope that this is actually the year that we can make this happen. So, so it basically, what it is it's a group. It's organized, and typically the way that many of these groups run now is there's a director, an associate director, there's access to someone that helps with the research, a PhD typically, or an Ed.D. that helps with the scholarship. But the idea is that it's really supported, and they run these interest groups in various areas, whether there's simulation, educational technology, critical thinking, residence teacher, many different areas. And they really provide sort of a catalyst to these larger initiatives. And when we want to consult a group of teachers and educators about, well, how should we look at assessment? How should we push the curriculum? This would provide a structure to do so. And so we've been looking at this very closely. The membership piece is tricky, and I want to thank many of you for serving on these informal discussion groups. It's been about 30 faculty that have looked at this idea. And the idea is we really want to have an inclusive group that will be truly interprofessional. So it's going to go across all the colleges and institutes. And we're going to look for people that have excellence in one area. It could be direct teaching, could be scholarship, it could be advising and mentorship and so on. But in fact, the way that successful academies are run these days is with the concept of service. And so when we come together, it's the idea that we're building something. It's not going to be for my career that I join the teaching academies, because I'm going to reach out to junior faculty and mentor them. And so for the course directors, for the senior teachers here that need people to run small groups, for the chairs that have someone that needs some coaching to sit in on their talks, on their small group things, this would be a place where you could go to say, I need someone to help me out, And from a faculty development perspective, if we want to coach people on doing learning objectives or this kind of thing, we certainly could do so by creating stimulus videos and this kind of thing. So we really think it would be a way to really bring this conversation into a real engaging and enriching community. So we did bring together several focus groups, and here's just some quotes from people that sat down and said, well, how would this actually change the tenor of the conversation for our campus? And one area is really becoming a national center of teaching excellence. So when they say University of Nebraska, do they still think football first? Probably, but and then medical care and health professions care, but also innovative education, and how do we make sure that we are always part of that larger conversation? Feeling supported, as we are innovating in our own units. Some departments have writing clubs, some groups have peer mentorship groups, but how do we extend that across campus such that you always have a home and really have a place to talk to? So I'm going to wrap up, but just to tell you that this is something we're very seriously considering. We have presented it to the Education Council, which is the group of senior associate deans here on campus, and we had a recent retreat on that, and we hope that if you have any ideas, you can come contact us. And really, I'd like to thank all the folks that have participated, and we hope that this proposal will be submitted to the Chancellor in September, and we'll have some news for you in October or so to tell you if this is ready to launch, and we'd have a big event in March to kind of tell you more about the Teaching Academy. So that's all I want to say. What we're going to do, just as a brief housekeeping thing, is that to cut down on time, I'm going to have the speakers come and briefly introduce themselves, and then move on to the next talk. And at the end, you'll get a time card from Linda when it's time to wrap up, and then you'll hear that famous chime when it's time to move on. Do you want to play that again for us, Linda? So, all right, so that's the signal for me to stop talking and for Dr. Nichols to step up. So thank you very much.
thank you to all of you. As I look out over the group here today, I think the majority of you have already been involved in interprofessional education in some way, shape, or form. And really, we could not make it work without all of you. Our IPE initiative here on campus depends on participation, obviously, from all of the different health professions trainings programs. And we've been very lucky in the eagerness of people to get involved. In fact, just yesterday, we had our fall IPE event with 500 some eager first-year students from across campus who all met in the Trulson Event Center initially to hear about patient safety and challenges with communication, and then broke out into about 45 different small groups, all running simultaneously with 60-some faculty facilitators in those small groups. And so these are wonderful events that we've been doing here for quite some time. And they're important, and we should continue to do them, but I think we, as Dr. Gold said, need to think about some of the ways we can really push the boundaries. We're not alone in our struggles to figure out what the curricular content should be for IPE. No one nationally can really say they know the answer to that. There is no national society for IPE right now. There is no national large-scale journal focused heavily on IPE right now. Those are things that are going to come, and I was asked to give you some big ideas for what we would like to do here on campus, and I think we have the opportunity to really fill some of those voids right here. We are in the final stages of discussions with Elsevier to establish a new IPE and interprofessional practice-based journal. The IPE half of that will be overseen by us here at UNMC in partnership with some of the other national leaders in IPE, and the interprofessional practice side will be overseen by a national practice group as well. The other opportunity I think we have is to think about hosting an IPE conference here nationally. We've started some discussions about that, and there's a lot of interest from our national partners, but I think we should set as a goal within the next couple years to host not just a regional or not just a UNMC conference, but a national conference, and I think that's very realistic. You're likely to hear from me or someone else in the IPE group to ask you for your assistance with that. It might well be that the proceedings from a conference like that could help launch our journal. Other things that we're focusing on, IPE in large groups has some value for covering those concepts that are in common for everybody. But the real primary goal of IPE is to make better team members and better team players. And that has to take place in smaller, usually practice-based settings. So we're going to be going out and looking to see where our students interact and where they're already in the same place at the same time, and try to develop smaller scale activities that really conform to what their eventual practice model is going to be. We've done some work with the liver transplant team, for example, already in this area. Geriatrics has done quite a bit as well. So we're likely to come and chat with you and ask how we could develop some things to help your students where they're actually doing their jobs. So I think that's most of what I wanted to say. Did I stay within my time period here? All right, very good. Thank you.
Thank you, Dr. Liu and organizers, for the opportunity to present a project that, on behalf of the College of Pharmacy, that we're working on. And I want to recognize, while I am presenting on behalf of the College of Pharmacy, this is really an interprofessional effort, and I want to recognize the individuals at the bottom left of the screen there from the College of Medicine, the Clinical Enterprise, and College of Nursing. So we have an idea, we have a project where we're going to look at implementing simulated electronic health records to enhance learning and interprofessional skills in preclinical health professionals. Our pharmacy students right now do not get education on electronic health records until just before their clinical experience. Even sometimes at the time they arrive at the site is when they're getting introduced to the electronic health record. We want to change that. We want to move that to an earlier point in the curriculum. Our specific aims for this project are to then better prepare students for the workplace technology, enrich learning experiences by increasing fidelity of existing cases. So we're taking paper-based cases, moving them into an electronic health record. So the student can Rather than having everything laid out in front of them on a piece of paper, they can go and discover in the electronic environment. And then we're going to create opportunities for the students to practice interprofessional skills by interacting through the electronic health records. The challenges, as I look out on the audience, I see some familiar faces, and I know you guys are aware of these challenges. And so what I want to say about this is we can overcome these challenges through projects like this. I know we can do this. So we don't need space. I don't need one room to house 260 interprofessional students or multi-professional students to work together. I don't have to have 65 small group rooms so that teams of 4 can work together on a project like this. I don't have to have schedules aligned perfectly so that we have to find one day and one time for all of the different professions to get together and meet to work on a project. The subject matter can be different for each profession as we work on a project like this. And then also being chair of the curriculum committee, I've learned I've got to be mindful of unwanted growth of the curriculum, and so I think we can do that in a project like this. So this group took an idea, and we're going to create an asynchronous case that was a M2 PBL case, an existing M2 PBL case that was baby Amanda. Baby Amanda has congenital heart disease. We're going to follow this child from time of birth to some clinic visits where the congenital heart disease is recognized, to a surgery, and immediate post-operative care of baby Amanda. The student teams will work through one chart. We'll get them sign-ons, and they'll work through baby Amanda's case in the electronic health record. So they're introduced to, we want to introduce them to the markers that you all are familiar with as well. CMS meaningful use criteria. Can the student sign on and identify the correct patient? Can they enter an order or some information into the electronic health record? These are outcomes that we're going to measure in this project. Now, the students do not need to be in the same place at the same time. They'll interact through this electronic health record at different times. We're using some flexibility of the playground environment in one chart so that we don't have to meet at the same time. Further, the students aren't going into baby Amanda's chart with the same purpose. This was a College of Medicine case, and the medical students are at a point in time where they're learning about heart disease. Thus, baby Amanda's primary problem is congenital heart disease. The pharmacy students are at a time when we're going to do this in their curriculum where they're learning about infectious diseases. We've woven into baby Amanda's case a need for vaccinations. And in College of Nursing, the College of Nursing students are at a point in time where they're learning about transitions of care. And again, we've woven into this case an opportunity for them to practice what they're learning in the classroom. They get to interact with one another through the chart. One profession enters some information into the chart, another profession gets to act on that information or ask questions maybe through the chart. Optimally, the students start interacting outside of the chart as well, emailing one another, texting one another to ask questions and to enhance their learning about this case. So, thank you.
Good afternoon, everyone. I'm Alice Shoemaker from the College of Public Health. And today I'm going to highlight 3 areas of which I think we are doing a pretty darn good job at: online education, interdisciplinary and experiential learning, and cutting-edge education. First, I want to brag just a little bit. Our student enrollment has grown 263% in the past 5 years, starting out with 69 students in 2010, and we're expecting 345 students this fall, so that has kept us very busy. Our college was created in 2007, and it's accredited by the Council on Education for Public Health. So, first of all, our online programs, we have 2 professional certificates, we have 3 Masters of Public Health with 3 different concentrations, and we have a master's degree in emergency preparedness. So this has kept us busy developing these programs, as you can imagine, changing our classroom to totally online computer-mediated courses. This changes our instructors' way of thinking. They have to understand how they're going to be teaching at a distance where interaction isn't always possible. We just are introducing our Collaborate interactive module with Blackboard. So we're hoping to see lots of interaction among faculty and students. We are interdisciplinary in our experiential learning. Our interdisciplinary, we have 7 dual degree programs. At UNO, we have dual degrees with information technology, social work, and business. And at UNL, we have a law degree along with our MPH. And at UNMC, we have medicine, physician assistant studies, and pharmacy through the PharmD. Every one of our graduates has to do a service learning capstone project in a community-based organization. So far, we have worked with over 100 community-based organizations, which gives our students a lot of practice in what is really a very broad field. So they can choose what particular area they want to work in, and they work directly with preceptors in those organizations. So that is really a great addition to our program. Another one is our Cancer Epidemiology Education in Special Populations program. That's a mouthful. We call it CEIFS. And this is funded through the National Cancer Institute and directed by Dr. Amr Solomon, who is our chair of epidemiology. This program provides our students the opportunity to go to sites in Africa, in the Middle East, and in working with U.S. minority populations. So far, they've spent summers in the centers in Cyprus, Egypt, Tunisia, Morocco, Ghana, Tanzania, Uganda, Kenya, and Malawi. These students come back changed. So they not only have this great experiential experience, but they also have a great cultural experience. And that's really what public health is kind of about if you've been reading the news lately. So we are really interested in how we integrate public health into the cultural experience of these students. Our cutting edge technology is demonstrated by, and she's sitting right here, our massive open online course, a MOOC. Anybody hear of a MOOC? This course was developed by Denise Brittigan, and it was funded through a campus educational innovation grant. It's the first one, I believe, that we are offering through UNMC. The title is Health Literacy and Communications for Health Professionals, and it's quite popular. She has only 4,500 students enrolled, and they're from 155 countries. So this is kind of an experiment. We're watching this carefully because we think this is not only a recruitment tool, but it also is kind of a teaser for other courses that might be of interest to students. These students use critical thinking and meaningful applications as they work with students of all kinds of disciplines and backgrounds. They're having interesting projects like communication infographics. I'm not sure what those are, but Denise tells me they're really important. Social media photo stories, and they also explore case studies from the news. And believe me, there are plenty of case studies in the news these days. So, public health is on the move. We continue to increase the number of students. And one more bragging point, our PhD students are 100% employed, which is counter to the national trend. They're working in academic institutions, in professional organizations, and also in some postdoctoral programs. Thank you.
Well, good afternoon. Thank you for the invitation to join you. I am speaking on behalf of the school and was asked to highlight some of the outstanding educational practices, and I'm happy to do so. There are many to choose from, and many of our faculty are in the audience. So what I have chosen to do is to highlight 3 areas. Some application of instructional technology, some things that we're working on in interprofessional education, and some areas I would like you to know about and have a little conversation about workforce advancement. You have seen maybe some publicity about our anatomage table. This is a product out of Stanford University. If you're interested in learning more about it, you're familiar with the TED Talk series. Google that and look up for somebody named Jack Choi, C-H-O-I, and there's a very nice TED Talk on the use of the table. It's a two-dimensional table. It looks like a giant iPad that you can use has a male and female cadavers. You can do a variety of different dissections, overlay, apply different anatomic areas. We're using it and deploying it primarily with our radiation science students. They have not historically done a cadaver-based dissection. You're able to import cases into this into the table. We've used mainly X-ray and CT, and so it's a very nice tool for them to be able to see things in relationship and in 3-dimension and in cross-section. Kim Michael and Tanya Custer are here. Do you want to stand up or at least wave your hand? They're the two folks that are using that if you'd like to learn more about it. Another area that we're deploying instructional technology is in the area of virtual microscopy. We use this largely with our cytotechnology students. We have been able to convert, the cytotechnology students look at glass slides and do screening. We've converted about 2,000 of those slides into virtual images using the tissue science facility here on campus. What's nice about this, it's a little hard to see up here, but it allows the students, we can put comparisons next to one another. The faculty can annotate around the slides. They can use it both live in class, and of course, you can send it across the world if we need to from a distance point of view. The cytotechnology faculty, Amber Donnelly, Dr. Mukherjee are in the back. You want to raise your hand at least if you need any more information about that. As a result of this work, both of these groups are doing a fair amount of educational scholarship around these areas, and the cytotechnology group was awarded a grant by the American Society of Cytopathology, the only one in the country to develop a completely online cytopathology course. This is a list of instructional technology. Betsy Becker is here. You might raise your hand. Betsy is rapidly becoming our in-house specialist on the deployment of a number of these commercially available apps, usually at no cost, some minimal cost, and using them to enhance instruction in class, get some immediate feedback, do some real-time engagement, some real-time testing. This is a list of many of the tools that she's used and explored. She'd be happy to talk to you about them if you'd like at some point. I want to mention a couple things about interprofessional education. Dr. Nickel mentioned that, and certainly we're all involved in it. I'm going to share two things that we're kind of at the beginning of talking about, and I share these with you because I think they speak to the question that Devin raised about what's the content and how do we move forward in terms of competency development. So Catherine Jones, is Dr. Jones here? Didn't see her. She's actually a master trainer for the Team Steps, the National DoD ARC training on communication and trying to reduce medical error. She's worked with a number of critical access hospitals, pharmacists, therapists, nurses, trying to improve workflow and decrease errors in critical access hospitals. They've also deployed this training in our PT program. We're talking about trying to figure out strategies to deploy it across our various programs so that all of our students would be able to leave with some of these competencies. The other thing that we're working on that we're very excited about with Dr. Liu and several of his colleagues, there's a huge shortage of mental health, behavioral health providers in Nebraska and nationwide. We're developing some, with PT and PA folks mainly, some modules, and with the idea of maybe putting them together for a certificate, thinking about how do our PA and PT personnel interface with patients in all the areas that they treat where they need to have greater understanding about diagnosis, surveillance, triage for referral related to mental health issues and behavioral health. So those things are forthcoming. Lastly, I just want to make a quick comment about workforce development. So I don't know, this is kind of a well-kept secret in the School of Allied Health. We have 175 health professionals across the nation enrolled in our degree, what we call degree advancement programs. They actually represent about 30% of the total enrollment in the school. So these are programs where in the allied health professions, you probably appreciate a number of folks enter with one degree, and they are often associate degree, certificate-based, some bachelor, but the programs that we now offer have master's or bachelor degree programs. And so for people who have a MLT, an associate degree, or a certificate in radiography, they may have entered the profession with a BS in physician assistant studies or perfusion. We offer them a mechanism to advance their degree while staying in their community of practice at their place of employment. We deliver the didactic information. They do their clinical experiences under our guidance at their home site, and then they have we advance their competencies but also keep them in place. Thanks. Jan Tompkins is the director of that program, so if you want to know how we do that, we're happy to share that with you. That was the end. Thanks.
Good afternoon. I bring you greetings from the College of Dentistry in Lincoln. Our big idea that we have to share today has to do with telehealth. Actually, this is the Tele Dentistry equipment that we have available for our students to check out when they go on their extramural rotations. They must do 6 weeks of extramural rotations in rural and underserved areas. They actually go to 2 locations for 3 weeks each, and we encourage the students to consider doing a teledentistry consult while they're on rotation. The equipment is very simple, basically a laptop and with a webcam and a microphone, and then we do check out an intraoral camera that can just plug into the USB port to be used. This is our developing telehealth network that we have across the state. Most of our sites are at FQHCs, VA facilities, and Indian Health Service facilities. Some of these facilities already have the video software and the equipment that's needed. They don't even have to have the students bring it, but we also have private offices and other facilities that are not a part of the network, and they can simply log in using the video software system. This is a map showing our dental shortage areas in the state. We currently have 20 of our 93 counties have no dentists, and 30 of the 93 counties have only 1 or in some cases 2 dentists, and most of those 30 counties, the dentists are of retirement age. So in the near future, the worst case scenario is that we may have 50 of our 93 counties without dentists in the future. And so while we may not be able to place a dentist in every single county across the state, we still can provide expertise to Nebraskans no matter where you're located. Our goal is basically to provide telehealth services for everyone if they're within 90 miles of a facility where we can connect through telehealth. This is a teledentistry consult because I thought some of you might like to see what our students do when they're on rotation. It's very learning centered.
Start to open your mouth, and then when you hear the pop noise, raise your right hand so I can see.
Okay, go. Do it again.
Okay. Can you open wider than that right now?
Yeah.
Okay. All right, and that's about as wide as you can. Okay, and close. All right. Where was the pain in that, where you have your hand right now, where you touched your face, was that where it was painful when you opened real wide?
Yes.
As she opens, can you feel the noise that she is describing, and if you can confirm as to when that is occurring, if it's happening at her maximum opening or middle opening?
Go ahead. Middle opening.
Okay, do you feel a closing click as well?
Go ahead and try it again. No.
Okay, that gives you a sense basically of what a teledentistry consult is all about. The patient was in Alma, Nebraska. It's about 4 hours from here, south and west. The whole consult took less than 5 minutes. Our student who was on rotation at that facility was able to see how to basically utilize the oral health expertise that we have available at UNMC in order for people to stay in their local community and sort of extend the reach of expertise across the state. So we're really excited about these opportunities for learning-centered education for our students, and we're also interested in partnering with other health professions in doing teledentistry consults. So if any of you have an interest, please contact me. I would love to visit with you. Thank you very much.
I have the privilege of talking to you today about something exciting going on in the College of Nursing. And I want to give credit for the title of my presentation to Dee Fink, who wrote a book called Creating Significant Learning Experiences. And that book started us on our journey toward the strategy I'm going to talk about today. So just a little background for us. A lot of resources have said to us we need to do something different in how we teach nurses, and we really need to make it more student-centered. So we started with moving to a concept-based curriculum. We used to have courses on peds, OB, psych, med, surg, and have moved away from that and have everything organized around concepts. So for example, we might have one that's health and illness. Within that is oxygen and hemostasis. And within that, we talk about clotting, gas exchange, and perfusion. And then an exemplar for perfusion may be shock, and we would cover the 5 of those. So then to talk about our strategy, we went with team-based learning. And some of you may have attended the presentations we had in the College of Nursing. But it's a very learner-centered strategy, and we believed would engage students differently, obviously, than lecture does, when, as you all are, kind of starting to sag in your seats. So team-based learning really employs about 3 phases to the process. Initially, you have pre-class preparation. Just as always, there are readings, there might be other activities which help the students prepare for the content that's coming up. And then when they come to class, they first of all take an individual readiness assessment test, which is a quiz designed to assess whether or not they got the concepts they were expected to get before coming to class. And the quiz can't be as simple as the sun is yellow, true or false. It really needs to require some thought on their part. After they complete the individual test, then they get together with their pre-assigned team and they take that quiz again. Now, we have not told them which answers are right or wrong. They just had an opportunity to take the test individually, and they will be graded individually on that test. They then take a group readiness assessment test, and one of the benefits to that is that there is learning in debate. So if you make it a more complex question and the answer is not readily apparent, as a team, they have to debate the answer and come to a conclusion. As a team, we give them the scratch-off cards. So once they've agreed on an answer, they scratch off the square corresponding to that answer. If they're right, there's an asterisk or some other indicator in that square. Great, they got that one right, they can move on. If they did not, they have to go back to debating until they are agreeing on another answer and they scratch off again. So they will also be scored as a group on their performance on that quiz. Once they've taken the quiz as a group, and they now get feedback on what's a right or wrong answer, they can appeal. If they disagree with an answer, and they have very solid rationale, or can demonstrate a resource that says their answer is right, then the instructor may give them the points back for that. At the end of that, the instructor has an opportunity, oh my gosh, I have time to finish. At the end of that, the instructor has an opportunity to give them more feedback. If they really just didn't get a concept, the instructor can clarify. And after that, the team application exercises begin. So they may be given a case study or another activity to work on as a team to really foster their knowledge of that concept. We also do an evaluation, and I've given you a blown-up copy of this in case you would like to look at that. They do this individually and as a group. And usually at the end of a concept or at the end of the class, faculty choice. And I've provided you some references if you want to explore this further, or faculty in the College of Nursing would be happy to answer questions you might have.
Good afternoon. My name is Kelly Kavrzegi. I'm the Associate Dean for Educational Strategy at the College of Medicine, and here I'm just reflecting a couple of the things that we're working on within the College of Medicine. I only have 2 slides, so not going to be going too very deep into things necessarily, but really what I wanted to try to do is reflect upon what the College of Medicine is working on, particularly around the curriculum committee. Really thinking about our curriculum redesign and what it is we can do to really adjust so that we better prepare physicians for the workforce that Nebraska needs, as well as our health delivery system into the future as well. The first slide is to describe, and this is effectively, I think, where Dr. Gold was describing in some of his opening remarks. Looking at our traditional way of doing at least medical education has always focused starting upon the curriculum. We have our curriculum and we define objectives to define that curriculum, and we assess whether or not you met the curricular objectives. And that's that historical time-based or traditional model of at least medical education. On the bottom half of the screen, I think has been very influential for me, and I think actually just kind of illustrates the direction with which the College of Medicine is moving, where we're focused on a competency-based education model. I'll ask you to focus on the center box there that says competencies or outcomes. Depending upon what language we're using, They're effectively the same thing. What I refer to it as is, what do I want my trainee to be able to do? What is the outcome I expect of my trainee to be able to do? And extending from that, and from that is the curriculum. I have to design a curriculum that supports my trainee meeting those particular outcomes. And then beyond that, if you go down, I'm not assessing whether or not they met my curriculum. I need to assess whether or not they met the intended outcome. And then finally, those outcomes can't be what's important to me. Those outcomes should reflect what the needs of the future health delivery system are. Whether that be the needs for Omaha, whether that be the needs for the state of Nebraska, whether that be the needs for our nation. So this is kind of just a framework with which I think we're accomplishing some of our work. This is a pictograph, if you will, that I think tries to capture everything that we're doing on one picture. So the yellow part, and if you look on the bottom, it says content of curriculum. Does the curriculum content and structure support the intended outcomes? That is really weird. Effectively what we're asking ourselves, so in May we had a curricular retreat to where we had the curriculum committee and extended faculty actually help to define what are those outcomes, what do we expect our medical students to be able to do. And then what we want to try to do from that is to go vertical and horizontal and ask ourselves, does our curriculum match or meet those intended outcomes? When we look across the 4 years and we look at each necessarily curricula itself, at each syllabus itself, are they integrated? Are they actually moving in the direction that they want to be able to go? And we need to do that through a course, over the course of a core, over the course of a year, when we split it to preclinical and clinical years, when we include our ancillary cores such as integrated clinical experience and PBL, all of those things need to necessarily be integrated. So go to the top, so look at the blue box where the intersect between the curriculum and the assessment. We can't just define our curriculum, we actually then need to assess our curriculum. Does the curriculum prepare our residents for prepare our students for entering into residency? In other words, do the students achieve the outcome that we expect? Is our outcomes achieving what we want them to be able to expect? Is it effective, efficient, and most importantly, is it evolving? Something that we as educators get really comfortable doing is comfortable teaching one thing, and then what can we do to actually, is that evolving? Is that changing with time? And then finally, the red part is the assessment of the trainees. Do the trainees actually achieve the intended outcome? Go back to that first slide. We don't want to assess whether the trainees meet our curriculum. We want to know, do the trainees meet the intended outcome? And by focusing on that, we can drive feedback. Some of the innovative things that we're doing is in our clinical rotations, our core clinical rotations have redefined the core of the assessment. What does that look like? We're actually asking our faculty, rather than being superior versus above average, we're actually asking them, can they do the expected skills of a medical student that we as a College of Medicine define for medical students across the rotations. So this kind of highlights, in a general sense, some of the work that we're doing and some of the work that the curriculum committee is embarking upon in really breaking it down into multiple different areas. The workflow, incidentally, the workflow part is probably nonsensical. That's just a way for us to think about how we're going about our work, but there's no real magic to that. And that's all that I had.
I'm Paul Paulman, College of Medicine, here to talk to you about simulation, and I'll be assisted by Patty Karstens, who most of you know does the work, makes me look really good, and I appreciate that. To show you how advanced we are in simulation and in the Sorrell lab, I'm actually a hologram. And some of you know me say, that explains a fair amount. I just thought he was lazy. But I can't actually touch some of that stuff. I'm going to talk to you about simulation. We're going to talk to you about a new group we're going to try to launch and some things that we're doing that could be expanded. So that's, you can read about our qualifications on the brochure if you'd like. So a little bit about the Sorrell Sim Lab. We're about 8,000 square feet. We have 16 clinical offices. We have 2 private patient rooms, emergency rooms, whatever. Virtual reality surgical simulation skills training area, which is new. Thank you very much to UNMC Foundation and Dr. Wayne Ryan for his generous gift.
As of 3 days ago.
Yes.
That's how fast we put that one up.
And a 600 square foot educational suite. We can record. We have over 70, I think there's close to 80 now, simulate patients who are superb, who can act out anything from, hey, how you doing? I'm here for my blood pressure, to I'm a victim of domestic violence. They're that good. So if you need a simulated patient, we have them. We hosted, actually Patty and her staff hosted over 22,000 learners last year. We can dress mannequins to suit the needs of whatever you need. So here are some examples. This is moulage. This mannequin here, you know, we tried to get Howard Liu to be this mannequin.
And he wouldn't do it.
These mannequins are expensive, people. We figured we would save some money by getting, get Howard up there. But have you ever seen, you never have seen somebody whine so much and complain about a few needles, a few students suturing on his arm, So I question his commitment to the simulation, but these are things we can do for the mannequins just to show you what Patty's skills are.
Well, it's just to help suspend the reality when the students are doing the simulation. Those were specific cases that we were sent pictures and we replicated it on the mannequins.
So I want to talk to you about a team simulation that we've done that could be expanded. One of the interesting things with interprofessional education is simulation lends itself to that to a degree. We did a cardiac arrest, team communications, using team steps as a background. And eventually we have gotten now to the point where we have all of our senior medical students, a lot of the nursing students in a certain unit, and pharmacy students working together to solve a cardiac arrest, mannequin-based cardiac arrest. Howard didn't volunteer for the cardiac arrest either. So they get together and they form teams, or they're thrown in together. They manage the arrest on a scripted scenario. They look at it, they switch up their team roles, they do it again, and then they analyze it. Interestingly, we've had some talk after and before the event, so that's generated some interaction among the students as well. So that's something that possibly could be expanded. We have the growing virtual reality suite. So if you haven't seen it in the Sorrel building, we're in the northeast corner of the basement, first floor of Sorrel. Come down and take a look at it. It's really cool. We have a robotic simulator. We have a laparoscopic simulator. We have a nice OR. We have a very good educator. Chandra Ari is over here, surgery. And his residents were doing a bleeding kidney the other day. And the kidney pumped blood out through a plastic tube with a pump under the OR table, and they had to find it and fix it before the patient lost that precious body fluid. So we hope to expand on that and become an accredited surgical simulation center. UNMC doesn't stop at Douglas County. We have a 500-mile campus across Nebraska. One of our missions is to bring simulation training. I sincerely believe that it makes patients safer. If we practice this and in teams more than individuals. And with the help of TNMC, are we still TNMC? I don't know. As far as I know. Prairie Health Ventures and generous donors, we have state-of-the-art full-body mannequins that can do cardiac arrest or can deliver babies, not at the same time, hopefully. They travel to community hospitals. We've had over 20 hospitals, 25 hospitals in Nebraska and the region. And the mannequin goes out, Patty trains the people, mannequin comes back, gets repaired, goes out to the next one. And there is a fee because Prairie Health Ventures is a commercial entity and they've recouped their money, their investment in it. We can expand this. The Helmsley Foundation is ready to give us lots and lots of money if we want to extend simulation even further. We just have to find community partners that are willing. Patty. Take it away.
This is our announcement. We have been asked by Faculty Development to start a simulation interest group similar to the Educational Technology group. So this is the start, the initiation of our simulation interest group. Everybody's invited. There will be information coming out to everybody. We hope to meet in September 18th at noon. Dr. Liu has very nicely volunteered to pay for lunch. And we will be in the Sorrel Center to start talking about simulation and doing some interdisciplinary talk and interprofessional collaborations about simulation in the Sim Lab. We hope to meet monthly, the third Thursday of the month. Okay,
are we still under time? Oh.
We made it.
I have some slides of my vacation in central Missouri. Next time.
Afternoon, I'm Mike Wadman. This is Chad Vokoon. We're from Graduate Medical Education, the College of Medicine. And we're going to be presenting some innovations that are really driven by necessity for our graduate medical education programs. And they are developed, implemented, ran by our program directors, some of which are here. And so when we mention those, we'll have them raise their hands so you can know who to talk to if you're interested. First of all, necessity really means that we have new competencies and we have limited time. So our program directors are tasked with teaching these new competencies, assessing them, but really not giving any extra time. And so we don't want to take away from clinical experience to add more didactic time. We want to make better use of our didactic time. So the first couple are dedicated towards explaining those programs, and then Chad has a couple, depending on the bell schedule, if we get to those. But that'll be Chad's problem since I'm going first.
20 minutes for extra time.
All right, sounds good. The first thing that we're going to talk about is M&M and the way that programs have transformed M&M from morbidity and mortality to a quality conference. I think we've all experienced M&M and in the past really has looked at individual failings, opinions amongst faculty as to what the best treatment is that are really based on anecdotal evidence. We're trying to transition that from complex patient or rare diagnosis to complex systems, and maybe not a rare diagnosis, but systems problems that really are the root of the problem. There's a couple different ways to do that. One program, our ENT program, Barb Haywood developed this. There she is in the middle. Using general categories that could be applicable to any program. And so we're looking at the IOM measures of safety and quality. And then using ACGME competencies on the other axis and asking ourselves as we go through each of these patients, for patient care, was it safe? Was it timely? For medical knowledge, what do we need to know to take care of this patient? Going down the line for the IOM matrix. And using that to frame the conversation so that these M&M sessions, these quality conference sessions are standardized so that you go through it in a very standardized process and really based on evidence that really has the evidence behind it so that what you're teaching has the weight of evidence so that you're really providing quality care. Another way you can do this is our surgery program. Dr. Ari has run this, is looking at really more specialty specific measures. And so using the SCIP measures, Surgical Care Improvement Program, looking at those things that happen intraoperatively, postoperatively to measure care. And going through each case using those to frame the conversation and using those to really bring evidence to the care of these patients. And so moving away from the old conference of really looking at individual patients and failings on an individual level to looking at them from a system standpoint and having the entire group of residents learn from that. The next thing we'd like to talk about is rescue, which is really experiential learning for our residents. We talk about residents being present in the hospital more than any other group, seeing the things that are happening when it comes to quality and patient safety, and using that as a resource. Recent studies show that residents, if they receive their training at a hospital that really has high quality patient care, high quality outcomes, that's the way they practice when they're graduated. So along those lines, having them in a group that really addresses these problems. It's an educational group. They learn the principles of quality and patient safety, take that back to their programs, but also start to participate in the process of analyzing these problems, being integrated into the quality triads within the clinical units and starting to address problems, starting to address real issues that are arising within the medical center. Most recently, looking at physician order sets. Who knows those better than the residents? Their input's valuable in making those decisions. I'll turn it over to Chad.
The next kind of innovative thing that we've done, and this stemmed from my program in internal medicine and has actually kind of spread, is our direct assessment of resident handoff. So when we move from shift to shift, from our day shift to our night shift, we have an observation form, which you'll see here. It's hard to read, but it's just there for a placeholder, is where we have a faculty member go in and they watch our residents hand patients off and we actually assess them. These happen to link directly to some milestones within internal medicine that we're being asked to look at. And the interprofessional side of this, which Devin would appreciate, is that now the formal checkout sheet that lands in our EMR, that lands in the electronic medical record, that shows to-dos, plan of care, things to watch out for, contingency plans and such, is viewable by, we're piloting it currently on 2 floors, but the nurses can now view this. So we all think we have Epic on campus, but actually what we see, what the nurses see, what the anesthesia doctors see, everything's kind of different. And we had to open up a gateway for the nurses to see what are the residents talking about and what are they checking out. It's improved communication without even talking to each other, which we do less of with the EMR. But so we're directly evaluating our residents. This is linking to milestones, and it's also giving more formal time where a staff member is with our interns, with our young learners, and showing how to do that. Chris Smith within my department has really championed this, and he's also started to do different types of handoffs, such as from the ER up to the floor. We've talked with Gene Simonson about when our patients go to the OR and then come back, you know, and how we can really transition handoffs. And so this is something that I think is cool, and we're hoping to grow this across campus and across professions. The final thing that we want to talk about, and this is using Paul and Patty's simulation lab, is we do Code Blue simulation. We've done it for about 5 years. Dave Gannon, one of our critical care docs, and he usually involves 1 or 2 of his fellows, have set this up. And so every one of my residents go through Code Blue simulation down in the sim lab. This is very interdisciplinary and interprofessional. We have anesthesia or critical care docs there. We have respiratory therapy. We have pharmacy. We have the whole gamut, and we go in and they run Code Blues. And we kind of sign off on our residents saying, hopefully, the first one you run is in a simulation lab instead of on 5 West or something like that in the hospital. And I've gone and watched, and it is amazing, first of all, how it can change a resident's view on, I can really do this. I offered you $20, Linda, to give us a little more time. Howard threatened me with a blow dart, and I want to see Paul's vacation photos, to be honest. So this is very interdisciplinary, and it's worked, and it's great use of the sim lab, and has really helped ease our residents kind of transition into that supervisory role. So happy to talk more. Okay.
Hello everybody, I'm Heidi Keeler, and I'm speaking to you on behalf of Continuing Nursing Education. And there's a lot of threats going on today. I was threatened with a taser if I didn't stick to my time, so I'm going to do the best that I can here. Innovation isn't always just about using new products or using new innovative, the latest and greatest thing. Oftentimes, innovation happens when you take these existing things, sometimes for many years existing, and use them in a new way. And so that's what I want to focus on, because we teach nurses, but hopefully what I want to talk to you about today can be applied to your fields as well. So the first one that I want to highlight for you today is our pharmacological conference for advanced practice nurses. And what we did with this is a program that's been running for almost 20 years now, using a traditional live conference format. Now, the challenge that we always have in continuing education is you have to have students in order to teach. Many of you are lucky you have captive audience students, but we need to get students in some way. So the challenge for us is trying to reach out to get education to all of the nurses across Nebraska and beyond, so that they can receive the education that they need. So this pharmacological conference, it's a live conference that runs in July, and it is live in Omaha. Now, 3 years ago, we decided that we want to try and reach out and bring this across the state. It takes 8 hours to go to the other side of the state, so we needed to find a different way. So what we did is we decided to take existing IP video technology and simulcast that out across to different locations. We chose the nursing campuses across the state. Now, we had heard that efforts to try and do this successfully didn't always end up with the learners' numbers that you need. So sometimes broadcasting doesn't always bring in the numbers and the people and the education to the people that need it. So we found that by doing this over the past 3 years, every year our attendance has increased. And the reason I think this happened is because we realized that people don't come to conferences just for the material. They come to conferences because they want to network, they want the conference experience, they want to have refreshments together. And so what we did is we actually set up that conference experience at those 5 locations across the state. The only difference being in the innovation is that the speaker, instead of being live, would be simulcast. Still have the opportunity to engage with the live speaker in Omaha. Everything else is the same. So we've been very, very successful with that. This past year, we had a 50-50 split. We had 50% of our audience in Omaha and 50% outstate. So I think that was a pretty big achievement. So the next one that I wanted to highlight for you is our Gero Nurse Prep course. And what Gero Nurse Prep is it came about from a Robert Wood Johnson grant in the College of Nursing by Dr. Mary Kramer. And it was a blended course. The blended course, we moved the blended course from Blackboard to an asynchronous, completely online program using all sorts of different open source and commercial products. You can see what it looks like here on the screen. We have a lot of interactivity, a lot of video features, and with over 800 students now in the course, we think that we probably are doing something right here. We'd like to expand on this course, moving it out to different topics and different levels of nurses as well. One thing I will tell you in all of this is we learned a lot about the process of how to create such a product. And so I'd love to speak with anybody after if they are interested.
Okay, now it's always interesting to be the last speaker, or pretty much the penultimate speaker. My name is Lois Colburn. I'm the Executive Director for the UNMC Center for Continuing Education in the College of Medicine. And what I wanted to talk about really were 3 different activities we've done. One that's completed, and this one is PROTECT, which is improving immunization rates through performance improvement CME. It was a multi-component effort that had received approval for maintenance of certification credit by the American Board of Internal Medicine, the American Board of Pediatrics, the AOA for their certification process, and the American Board of Family Medicine. Along the side, you'll see that this is just taking out what our experience was in nesting something that included self-assessment, chart audits, and other educational resources. And this is from the adolescent module. And over the course of a period of time, we were able to, within clinical practices, improve the immunization rates for various CDC-recommended immunizations. And this is held true across all of the modules. What we've learned is the biggest issue really has to do with systems approaches, putting in place those kinds of things that facilitate practice. It wasn't knowledge. Everybody pretty much knows that you got to give the immunizations. It was, what is the practice doing to facilitate the process? The second element is an effort that we recently received funding from Pfizer on the basis of a request for proposal in collaboration with the lymphoma group within the Division of Oncology. And what we're going to be implementing with rural clinicians is really to look at how can we improve the outcomes of rural patients treated in a rural community. It isn't that rural patients in general have poorer outcomes, it's the location of where they receive treatment. So we're doing a very formalized telehealth weekly case conference. There's going to be a consultation hotline. There are going to be other resources. There's going to be a second read for pathology. And the data, ultimately the success of this is going to be evaluated by data submitted to the Lymphoma Study Group database. Finally, we've got a new one starting. I'm excited to see what this is all about, but we're taking a very traditional journal online CME effort and adding augmentation using some gaming. It could be things like crossword puzzles or so forth to reinforce the learning. We do traditional things, but I think the more that we move into thinking about how can we innovate this, how can we make it relevant to clinical practice, we really will have accomplished something. Thank you.
Please help me welcome Dr. Deli Davies.
Thank you very much, Howard. Listening to all the presentations, one thing that struck me is really the quality and the depth of excellence we have in our educational programs here at the Medical Center. But one thing that also strikes me is that I didn't know half of what I heard. I mean, it's really I think, numbing to think that there's so much innovation going on, and most of us are hearing about it for the first time. I think that really highlights the challenge that we face if we truly want to become the very best that we can be in education. We really have to think about how we work together and maybe make these efforts known more. And that's why I really commend Howard and the faculty development group for arranging a day like today. But I think that really brings us into the idea that we're going to be presenting to you today. There's a tremendous change going on in the world of education. There's tremendous change in technology. We heard Kelly Kawasaki talk about the changes that are going on in how we view education in terms of moving from assessment based on what people should have known based on the content to what we expect them to know based on where they're supposed to be going. And really the question for us is, how are we going to handle this change? And are we going to be followers or are we going to be leaders? And are we going to have an opportunity here to add content that will make us of value as we move forward? So let me just frame that very carefully. In about 5 years, some people will say maybe 2 years, everything we teach right now, somebody is going to have it for free online, guaranteed. Either for free or they're going to have it in a way that they are the ones who have the content, and we're going to have to either buy it or we're going to have our own content that we actually also use to trade. So this is going to be the currency by which we talk to one another. The generation that we're teaching right now, they know how to get information. They're not interested in us giving information. What they want to know is how could they use that information in a meaningful way. So basically, what we're thinking about here is how we can harness this into something we're calling IXL. And basically, we want to be leaders in transforming health education. You already have shown, based on the presentations today and what I know about what a lot of you are doing, that you are leaders. And I will tell you that a lot of these ideas spurred by a visit that we took to Toledo, where Chancellor Gold has formed this Center for Creative Education, where experiential learning, where a bunch of us went, and we went to basically look at what he had developed there. And we didn't really want to necessarily recreate what he had there, but we were thinking, what could we do here at UNMC that would allow us to address these challenges that I just talked about? And these are the people who went. I'm not going to spend too much time on that because I really want to get on. I know everybody needs to leave by 2. But one thing that struck me was that there was a lot of, they had a beautiful building. By the way, this is like I believe it's a 40,000 square foot building. It was a beautiful building, lots of technology. But I will tell you that we have almost all the technology they have there. That's really not what excited me. What I think really intrigued those of us who went was the integration. And what the integration allowed them to be able to do that we're currently not able to do. But we're on the verge, based on what we already have and based on how we're interacting with one another. We're on the verge of being able to do what they're doing. And in fact, the people there, based on what they know about us, because actually one of their leaders came here and saw what we had, thought that we're actually way further ahead than where they were when they started. And so here's really some reflections about how we're different, and I could tell you what we observed, but it'll come out in my comments as we move on. But creative and experiential learning is going to be the norm for education of health professionals in the future. So it's not going to be about sitting in lectures. It's going to be about simulations and interactive learning and online, and then the classroom is going to be more for interactive learning, not for that kind of. And then we talked about competency-based. At the medical center, we have superb. All kinds of tools, and we have all kinds of enduring curricular changes that are going on. The challenge is that they're siloed. And these silos limit the opportunities to innovate and maximize educational research and healthcare opportunities. And this impacts us locally, across Nebraska and globally. One thing they've been able to do in Toledo, by being the first entrant in this area. So what do they have? They have a lot of the same things. We have simulation. They have virtual reality caves where they can do immersive 3D things. So you can actually do everything from research, where you can take a cell, blow it up, and literally walk on the cell and look at the surface of that cell and think about how another molecule may fit in if you're a pharmacologist. Or you can actually have virtual reality where you can take a heart and walk through the heart and see what the valves look like. right there and actually interact with it directly. But more importantly, what they've been able to do is by working, getting all the different professions to work together, they've been able to create very interesting curricula that there's a big vacuum right now in this area. And so they're creating the content for this right now as we move forward. And they've also been able to attract a lot of attention from the military, from industry, and it's allowing them to have partners that's actually changing the way that we want to think about education. So we have a unique opportunity to be pioneers in integrated use of technology tools for creative and adaptive experiential learning. So here's a vision. This is not my vision. This is a vision that's jointly formed by many people. Certainly all those people were involved in the trip, but it's gone now through the Education Council retreat, and this is really the vision. Now we are the global leader. UNMC is the global leader, game changer, in integrated, interprofessional, and interdisciplinary creative and adaptive experiential learning for the health sciences and beyond. Now it's a very bold vision, and we recognize that. But the reality is that if we truly want to have an impact in this area, we have to either decide we're going to be bold and be one of the leaders, or we're going to have to just wait till somebody does it and then just buy the products and just say we're going to just be part of the whole crowd. So here's the premise. Transformation of the educational experience and health outcomes occur when creative and experiential interprofessional health science learning is delivered contiguously and integrated over a lifetime. What do we mean by that? So here's we have a lot of pipeline programs that we have a lot of students that we're teaching before they ever show up to the medical center. We have programs that we're dealing with pre-K, K-12, all the way down to graduate, postgraduate, continuing education we just heard about. Patients, ancillary groups that we interact with and we teach them. The question is, how do we integrate this in a seamless fashion so that when we're moving from one level to the next, it's pretty clear what the connection is. And that connection is fairly well defined, and we can actually make sure that it makes sense. And of course, I talked about the opportunities for basic science here. So this is the curricular part, is where we can get our curricular committees together and think about how we can actually truly integrate as much as we can, not only across disciplines, but horizontally from K to 12, or vertically, whatever you want to call it, from K to 12 all the way up, and see how that all flows. So if I have a module that I can use that module not only for nursing and for medicine, but I can actually decide, okay, if I have 6 of these modules, maybe the first one can actually be good enough for high school kids that are being taught through our High School Alliance and so forth. But above and beyond that, we also have all these tools. Actually, we have all these tools that we've been talking about: interactive learning, the wall for 3D. We have simulation, a whole bunch of things that if we could actually harness them in a way that they're actually together. So you can have a child come in, or a student from any profession come in, have an interactive online learning class, come into class, have a flipped classroom, go from there to a simulation exercise, go from that simulation exercise to a virtual reality exercise, and move from there to a virtual hospital before they ever step in the hospital to see a real patient. So that patient will never have to worry about July and change of rotation, because that student will actually have done a lot. So it creates opportunities for advanced interprofessional and interdisciplinary education. It leverages the interactive educational activities across the educational continuum. And actually, here's the key: human performance. We're going to be assessed, we're going to be paid based on quality and based on outcomes. We just heard that. And this is all about human performance. We need to have a way where we can actually make sure that we're evaluating, we're training our students and our faculty in a way where they can maximize quality and outcomes of care. And then research and best practices. We can cut down infection control rates in the hospital to 0% by simulating it in the virtual hospital before we actually show up. Dissemination of practices. If we enhance and integrate better how we're not only located, but how we communicate with one another, then we can actually adopt best practices very quickly. So rather than waiting to come to an excellent conference like this, there'll be opportunities to actually have other people adopt good ideas. So gives us opportunities to partner with the military, other universities, industry, intellectual commercialization. And Allied Health, for example, Cal Meyer pointed out that they're having more and more pressure on clinical sites, and we all are, I think, the same thing for medicine. But it's going to get so good and so real that we can actually use not for all experiences. We should be able to use simulation and virtual reality for a lot of them as we move forward. Improving health outcomes, and also allowing us to coordinate in a way where we can reach all of rural Nebraska and actually around the globe through all these things. So what do we need to be able to make sure that all these things happen? We need to be able to think about how we can co-locate all our tools, and I'm going to talk about that. We have to make sure that it's accessible to all our learners, from our medical students, nursing students, pharmacy students, all the way to our alumni. Oops, excuse me. It's got to be sustainable, because we all understand that educational things are not easily funded, so we've got to make sure we get the money for it. It's got to be coordinated. Outcomes are going to be key. If we can't show that we're having any better outcomes than with the current traditional way of doing things, it would have been a waste. We've got to make sure we implement it, and it's got some challenges in there. So can you imagine having all these things? These are sort of the tools that we've talked about today. Many of them we've talked about today. But rather than having them siloed, or at least having a sense of how each one is functioning, this is not saying everything has to be under one roof, but we have a sense of how they're, coordination of how they're working together. So we have the interactive e-learning laboratory, flipped classrooms, the caves, advanced simulation, surgical skills center, virtual hospital, telemedicine network, standardized, certified testing center, faculty advanced teaching academy, cost center for blended learning, all of these integrated in the fashion where we know what's going on in all of these areas, and we can actually program them in such a way that each one of them is taking advantage and they're actually making sense, so that what's happening in simulation is not happening independently of what's happening with virtual reality or with interactive learning. Doesn't mean that one is going to stop the other one from doing it, but we're all aware of what's going on, and it allows us to create curriculum and actually to make sure that we're taking advantage of the innovation that's been made in one area, enhances our ability to actually make things happen in another way. So this idea of co-location will also serve as a hub for reaching, for example, if you're a College of Nursing with all your different SIM sites, you can actually use that to coordinate all those SIM sites. So it will enable us to actually be able to provide better competency-based care. So accessibility, I'm going to skip through these very quickly because I know that we're running out of time, but basically we want to limit barrier to usage, make sure that it's readily available to the clinical enterprise, the community, and low barrier by all other groups. And we want this to be truly a global destination for innovation. In order for this to be sustained, we know that we're going to need a lot of philanthropic support. We're going to have to partner with the industry, and be a luminary site for some major partners. Intellectual commercialization, partnering with the military. We happen to have a strong military presence around Omaha, and they're very interested in human performance, and that's where we can work with them. And we can learn from them, they can learn from us. And coordination, so the key thing here is that, the building is irrelevant. It's not the key. The most important part is the coordination, the programming, how we think about this. And this is going to take a lot of effort, and we all have to sort of decide that this is where we want to go, because this is going to take an incredible amount of effort from everybody, and to allow the curriculum committees to think about this. We're going to have the hub and make sure that it's interdisciplinary. We have all the right players that we need. And we're going to have to keep on top of what's going on nationally to make sure that we're there. Again, it's got to be something that we show that it's working. We've got to make sure that we're looking at outcomes. We're looking at all the different potential opportunities to present our findings nationally and internationally. We have to have dashboards for the technology and other innovation. And we've got to have partnership and other types of collaborative dashboards. And most importantly, if it's not fiscally sustainable, it will, no matter how good it is, going to just end up fading away. So the issue here that we talked about at the retreat was the fact that we need to really move quickly if we want to be a pioneer. We're currently well positioned, but if we want to be truly a leader, we can't be one of the last entrants or one of the middle entrants. We have to be one of the early entrants in order to catch the whole opportunity for the advantage that we would have. We have local philanthropists that are very interested in this, and again, they're not going to wait for us forever to come up with the ideas. And then we have industry and military partners who are also very interested in this area. So we do know that we have some challenges, and that's really making sure that we all work together. I think this can be overcome. I know that because I'm on the Education Council. We work together all the time, but these are some potential challenges. Make sure that we engage the clinical enterprise, and it's not a UNMC issue alone, it's for both sides. And make sure that the curriculum committees on all the colleges are working together. And we have to have an organizational culture that supports this vision of the future. So here are what we're calling our next steps. We're in the process of putting together a guiding coalition. We're going to be seeking internal and external constituents. Virtually everybody in this room will be touched for your input at some point. We have to get campus support for informational communication, and get the philanthropic support for it, and secure structured organizational approach. I'm going fast, but we had this retreat, and virtually everybody was strongly supportive of that. We had 35 members participate in that, and this was one of the things that came out of that, was that we should move ahead with this. And so I ran through that very quickly because I'm trying to make sure I'm not the one. Actually, I think I'm right at 2 o'clock. I was given 15 minutes. I think I just made it. So, Howard, questions? Okay, questions? Everybody's tired. Okay.
Well, I wanted to thank all the speakers, and thanks to Dr. Davies for giving us our closing talk, and really just such a rich array of ideas here, anywhere from, how do we do better simulation, to how do we bundle programs together, how do we make sure that we're teaching concept-based curricula, how do we make sure we're moving things in competency-based ways. It's really a very rich array. I know that some folks may have to leave, and that's fine, but I would invite us to ask any questions for any of the speakers today and see if there's any questions people have. I'll just open it up now. I think we do have a roving microphone if we need it. So any questions anybody has for any of the speakers? I'll leave it out there. Okay. All right. Yeah. Go ahead, Myron.
Talks here. One of the things I noticed was that there were no presentations from the basic sciences in the College of Medicine, in particular here. And my suspicion is that part of the reason for that is that those of us who are basic science faculty in the College of Medicine can write grants and have a guarantee of supplemental salary in reward for putting in extra effort on the research side of our lives, and nothing comparable if we decide to put in extra effort on the education side of our lives instead. So not really a question, but a comment that I would encourage you, Dr. Davies, others who are highly placed to figure out how to make excellence in education have a built-in reward that is comparably satisfying as the guaranteed supplemental salary that research faculty get. Otherwise, I fear that at least in the basic sciences, we're going to end up with full-time teachers who don't do any research and don't keep up with what's going on except for their teaching, and full-time researchers who do no teaching at all. Certainly moving that way in our department. So I just wanted to use this forum to encourage some thinking about that. Thanks.
Well, thank you very much, Myron. I think that part of the challenge you're highlighting is that we did go through many presentations today. Actually, we could not feature everything on campus, but as each of these folks from your different colleges and units are thinking about how to build these programs, these bold ideas, I think it is to keep in mind this principle of being inclusive. I know that there's a lot of pressure on faculty for their time, both on the research end, also on the clinical end as well. And so, I think that is a great comment for our leadership as well, to think about how to incentivize education and make sure that that's one of the core mantras that we keep going for all of our faculty. So thank you for that comment. Any other questions? Go ahead. Greg.
I had a question for Kelly Kamerzagi. In terms of the move to competency-based education, how important or how integral do you see the simulation piece that Delia was just talking about?
So how important a simulation is in meeting the outcomes, that middle box on the bottom of the screen, in meeting the outcomes, the part that I believe is missing on that graph is actually the link between the curriculum and the assessment. They actually have to work together. And if you notice in the yellow flashing box that I had, the yellow part was the structure and the content of the curriculum. So some of it is just the content. We actually need to know what our outcomes are and design curricula designed to teach that. But also that structure part. And that structure part isn't necessarily just me delivering a lecture to somebody or me training a student on the wards. It involves all of our different modalities, all of the different structures, all of the different curricular elements that go to deliver that. And one of the crucial ones, I think, is simulation. Simulation that Paul and Patty had mentioned, simulation that I think Mike and Chad had mentioned as well, but also that interprofessional piece that Dean had mentioned as well, is actually taking those opportunities, taking the times where our curricula do intersect. So taking the box that I had, and not just for the College of Medicine, but for all of our colleges, you can apply that same principle. Where does the curriculum and where does the assessment intersect? I'm sorry, where does the curricula, where do the outcomes intersect? Those are our opportunities to use simulation. Those are opportunities to use interprofessional education, so on and so forth.
Great. Any other questions for our speakers today? Okay. Otherwise, I'd like to give a round of applause to all of them. Thank you for your bold ideas. And certainly you're welcome if you have time to linger and ask people questions individually, but thank you so much for coming, and we appreciate you helping us make this event a success. Thank you.